measure incidence.
Okay, I think with that, even though I haven't really had a good round with our fantastic panel, we'll just go and see if see what questions and comments you have, and give the panel a chance to wind up on anything at the end if they want. Please introduce yourself, please, when you ask a question.
I'm with Results Educational Fund.
I'm Mandy with Results Educational Fund. And my question, I guess, is for Mead about equity. I'm wondering if you reward countries that have improvements in outcomes, then are by default you punishing others, and are people who live in countries who are unable to achieve these results getting an unequal chance to get access to treatment, which is something that the HIV community cares a lot about, equal access.
Okay, we're going to collect several and then turn. Bill McGreevy? And if you have a question for a specific person up here, please say so.
That's
a good idea, actually.
Just asking, cash delivery for what? Cash on the what is delivered. It's not a package from UPS. Maybe what you want to talk about is whether a donor and a government could agree, in fact, have a whole discussion about what they might want to deliver on. And then, just as you're suggesting otherwise, maybe we could have an agreement with some governments and not others. That might be a way
right.
to
So
think of it.
Definitely the idea is an agreed goal, but you might want to clarify what exactly again in what you're talking about. Others?
Yeah.
In the back, far in the back.
Hi, my name is Matthew Morton from the University of Oxford. Appreciate your presentation. And I'd like to get more, as Nancy started to get to, what do you mean by hands-off? And I was thinking about the presentation by Ken and how this could lead to further innovation, but I wonder if that might be a euphemism for reinventing the wheel, and if in fact we might go more adrift from evidence-based practice, which MRC model suggests. We might be able to evaluate and achieve impacts and assess impacts, but then follow a logical continuum where we adapt models to local contexts and better understand implementation science in that way. And wondering if this will move us further away rather than closer to it.
Okay, that's a good question. One more, Nancy.
I'm Nancy Padian from today from University of California, Berkeley, and I'm sort of on I am in fact in Jimmy's camp, where I think that 8052 was a game changer. But for me, the main reason why it was a game changer is it completely blurs the distinction between treatment and prevention. So, which means that it's a little bit harder to follow this. But getting back to what Ken said, I wonder if the room for innovation at the community level is actually having to do with adherence and retention on treatment. Because as Mead said, and he's right, Mike has said this as well, that is really high quality, well-monitored treatment. And if you follow our treatment cascades in terms of when someone gets tested to staying on treatment, they're abysmal. And to me, one of the crying needs, which really is highlighted by the fact that treatment is, we need to think of treatment as part of prevention, is innovative ways to really focus at a community level on adherence and retention in treatment or prevention.
Okay, maybe what we could do, okay, Maureen Lewis from the World Bank. Maybe then I'll see if anyone else has, and then I'll go back to the panel, and you won't have another chance after Maureen unless you put your hand up.
Desperate. Okay, thank you, Nancy. Thanks. I really like this panel. You came with lots of different perspectives. I just wanted to follow up on some of the comments that had been made, because I had some but are slightly differently. I think on this cash on delivery, if you can get it at different levels, you may be better off than doing it at a national level, because you can also have a situation where 20% within a country are doing really well and the other 80% are doing very poorly. And you need to have some way to parse that if you're going to be able to give rewards where things are actually working well, which gives, I know you don't like the word incentives, but I actually find it a really useful thing to have. And it gives incentives to others who see this to do better. So I think that it's important to see it at a local level, at a state or province level, and as well as at the national level. And the second point I wanted to make is that treatment and prevention, unfortunately, they can be the same thing, but it's an extremely expensive way to do prevention. And we do have examples of countries that have done prevention extremely well at a much lower cost. And both Brazil and Thailand did that, as did Rwanda. So you have 3 countries that have been quite successful. And one of the things that they did, although they didn't monitor infections, they monitored prevalence continuously, and they could see the changes. In fact, I did a projections model in the early 90s that Mead was my commenter on, and did have criticisms, but was largely supportive. And the Brazilians still use this and say, see, our prevalence is way down. And the World Bank said we would never get there, which is not what we said, but it's okay. It was essentially an incentive for them to sort of say, guys, we did it, and you thought we couldn't do it. But they got a lot of money from us. And then when they did well, they got more money. So it wasn't quite cash on delivery, and they would have gotten it anyway, unfortunately. Or we could look at it that way. So, thank you.
Okay, anybody else? Yes, one more. Oh, 2 more, 3 more. Okay, if you're quick, and then we'll go for last round.
My question is, sorry, I'm Juliana Kohler from Deloitte Consulting, and my question is related to many of the others that have come up, but I'm wondering how to deal with country ownership in countries like Ghana, where I used to work, where the government was mandating that, well, not mandating, but the government was prioritizing youth and general population prevention, and it was actually the U.S. government that was spending all of its money working with most at-risk populations, and it took, I think, around 10 years of U.S. government funding MARPS prevention before the Ghanaian government finally said, okay, yes, this is where we need to concentrate our funding.
Okay, great. That's a good question. Thank you very much. Yes, please.
My name is John Osik, and I am from Apt Associates. My question is regarding the cost and the feasibility of COD when you are dealing with governments whereby governance issues may be a challenge. I'm giving this question based on, for example, the experience of the Mo Ibrahim Prize, which was given to governments and presidents. In case they do a good thing, then they get a prize. But it hasn't been taken up and hasn't brought the results we want. How do you think this is going to do better than the Mo Ibrahim Prize for incentives to governments?
Okay, one more. Thank you.
Beverly Armstrong from IRD, and mine is a practical question too. In other places I've worked with Pathfinder, with PEPFAR funds, with just implementation, I know the on-the-ground reality of how the urge for more accountability of government funds and global funds and with all of the issues around that, the prospect that anyone is going to say, here's some money and we're going to be hands off. We had a very
okay, so no, come to your question, okay, because sorry.
We had a lovely story.
Or it's okay, this is a good comment, that's enough.
In Tanzania, I think it was, that people were bonding together and only one in the group would go and get the antiretrovirals, and then they would encourage one another to take. And I was just thinking, oh hell, nobody would let him sign for 8 doses because that would be seen as graft and corruption in any of these programs.
Right. Okay, thank you very much. So Mead, I'm going to give you the last word, and I'm going to go through the panel and give each person a chance to comment on anything you heard. I'm going to ask Mead to try to lay off the many good questions about cash on delivery and instead refer everyone to the book, although you could say a little if you want. But a lot of the issues you've raised are addressed in the book that's on our website called Cash on Delivery Aid. About reputation, about hands-off, about national versus local, about equity, right. And I'm very encouraged to hear that there are these good questions about an approach that can apply across a number of areas, maybe more difficult to apply in the case of HIV than in some other areas. David, maybe you could address the point that Nancy raised about are they merging together, treatment and prevention, or is it sensible conceptually and practically to still maintain some sort of a difference in thinking about what to do next?
I think Nancy raised a really positive point, and that is that we have an added reason to do prevention better. It has a great treatment benefit. We have an added reason to do treatment better. It has a great treatment effect, and it also has an added prevention benefit. I also agree with other commentators, including Maureen, that in an optimal world it would be an expensive way to do prevention. And if we look at countries with concentrated epidemics, we actually have some low-cost solutions. India's managed to avert about 70% of its epidemic through low-cost interventions. I'm not convinced we have low-cost behavioral solutions in generalized epidemics. I think we are largely back to the things that we've talked about, treatment for prevention and male circumcision. And my closing remark is, what I found poignant about Hillary Clinton's comments about a week ago is, 10 years ago we went to the world and we said we need billions more and we don't know what works, and we got it in a different economic environment. Today we're going to the world and we say we know a lot more about what works, but we're saying it to an exhausted system. And I just think unless we can do things radically more efficiently and effectively, we're not getting more money.
Let me go next to Jimmy on that and ask you two questions. I forgot, like Rick Perry. And they were so good.
You can have a makeup
Oh, I know what it is. So Kenneth said, what else do you suggest? He said in talking about the book, if you're a critic of the approach Mead is taking, could you, Jimmy, put yourself in a world where in fact resources are not increasing and might be declining? What else do you suggest?
Well, I'm clearly not the expert on the drug research part of this, but I think that the cost of treatment, there are some real options. There are new drugs under development that could be more effective, less toxic, cheaper, probably more effective, and that the assumption that we can't put more people on treatment, that it's the cost of treatment which is the fixed item, I think is one that we have to fight against, both and more effective ways of delivering that treatment. But I also think that we're in the United States. There are treatment waiting lists in some states in the US, but we have made a commitment to provide that treatment for everyone who needs it here. And I think to not do that in countries where AIDS is taking a huge cut in productivity and in affecting families and so on. I mean, for every these figures are from PEPFAR, but for every 1,000 people on treatment, there are 449 orphans averted. Every 1,000 people put on treatment every year, 449 orphans averted. There's 60% of the treatment costs are covered just in the averted deaths and sickness there. And if you talk about the productivity gains of the people who are healthy and therefore able to work, the treatment costs, this is a Global Fund Harvard study, appear to be actually net positives. So I think the question of limited resources is what time frame are you talking about and how we can get the discussion to be talking about investments. I think you can't be naive and say that the U.S. budget is going to continue to go up. On the other hand, with national contributions, especially in some of the key countries going up, we need to leverage what we're doing in a more effective way. And I don't know, a couple of the comments I wanted to respond to quickly, but
yes,
you're...
and I did cut you off. You can
No,
take
that's
another
okay.
minute.
I was being mean.
You can have another
I was
minute.
being mean, and I won't be mean. The question about Thailand, for instance, which had an enormous drop, and I think that's a great example of performance-based incentives, but the rewards or penalties were to brothel owners. And when you had brothel-based sex workers and you imposed some rewards and punishments on the brothel owners, that worked very quickly to do that. I think that, we need to think creatively about what that tells us about other models with other populations. There are not a lot of brothel-based sex workers in the high prevalence countries in Africa. But that's
okay, I'm going to interrupt you again,
Okay.
Jimmy, because Lori has to go, and we are way over our the expected time. And
Equal access to HIV, though, is a question of why we would want to use
I'll come back to you.
percentage of treatment need.
Lori, maybe you could say something about a larger question I have in my mind, because you probably followed this HPN 052 business. Is there a possibility that that finding, if better understood and explored, and would generate additional money somewhere? Because like going to the moon, it holds out, people can think, okay, now we could really do it. Let's go for it and do it.
No.
Very good. Very good. Barney Frank would love it. Thank you very much, Lori. Jimmy, did...
Sorry, I just wanted to make the point about the equity, that I think that the question of, the question of how to deal with good and poor performers is more complicated, and in that context I wanted to question how, if we made a multi-year commitment as the U.S. or as the Global Fund or anyone else to meeting a prevention of treatment need in DRC, because the percentage of treatment need, that's what I meant to say. In DRC, that number could keep growing, and it would be a result of poor performance, whereas in countries like Botswana and Rwanda, nearly everyone who needs treatment is on it. And so the way we would support those programs should be in improving quality of treatment and so on. And so I'm a little bit worried that a formula like that would ignore some of the real questions of what do you do with people whose governments aren't good performers but nonetheless are in great need, and that is chronic and multiplies over time rather than would be reduced by a kind of cash on delivery formula, I think.
Kenneth, what would you like to say? You made me so happy before.
I just wanted to point out, Nancy made a comment about and David also pointed out this cycle where the prevention and the treatment helps the prevention and everything like that. There's absolutely nothing in what Mead has proposed that doesn't take advantage of that, right? I mean, he's leaving it up to the local countries to figure out what's the best way to achieve treatment, and to the extent that to achieve prevention, and to the extent that treatment is the best way to do that, if it turns out to be the most cost-effective way, then that'll do it. I think the only game changers that we're going to discover in this, and I think we should be, the scientific community should be working overtime to find these game changers, is a cure or a vaccine. Those are the only game changers, and everything else is going to be a combination of these types of things. I think there's absolutely no way in which we should talk about, stopping to treat or retreating in those types of things. The point is, in order to achieve the age transition, which we are not going to achieve by 2015, I'm a little surprised to hear that. I guess it was a particular type of transition we're supposed to achieve by 2015. It's really around the corner. In order to achieve the age transition, we have to start dealing with prevention in the absence of discovering a vaccine. And that's, I think, what this is all about. The really quick comment I wanted to make about cash on delivery, I'm not afraid of the word incentives, Nancy, Maureen, but I'm just careful about using it in public settings. But the thing, the immediate instinct that people have is, let's find the person at the local level. So someone even mentioned community, right? Communities aren't in here at all. We're talking about national governments. There's no mention of like the U.S. government contracting with a community. We, in this room, cannot go out and find who is the individual who we think is most likely to come up with the innovation. We can't do that. That's not going to happen. This has to be left up to nations. And some nations will divide it up to the states, and some states will send it out to the districts, but some nations won't. And, more importantly, there will be horrendous failures. Programs will be tried that are failures that we could look at and say were failures, but I'm sure that Mead would agree with me that as soon as we got up from this bench and went and sat down in the audience, we would chastise everyone here has been part of massive failures. Directed from here. We have all failed and done incredibly stupid things. So the idea that we're not going to change things around because we're afraid that someone else might do something stupid, I mean, what is that, right? I mean, that's crazy. Of course there will be mistakes made and that kind of thing. That's not the point. No one is saying cash on delivery is going to find only the right answers without making failures, but we need some help. And I don't want to tell a country that that the community is the one that's going to be the answer. It could be different in different countries.
Thank you very much, Kenneth. Mead, I've really taken all your time away, but people have said good things.
Well,
about
also
your
the audience
book,
has been very patient, given that the
The food is outside.
The food is outside. So thank you very much, and thanks for these comments. And I do take to heart Nancy Padian's point about how incentivizing adherence is also important. I want to really stress the fact that I'm in this entire book. It's true that HPTN 052 had not yet been published, but it's also true that I was aware of these results. There's nothing in the book that excludes the fact that treatment could be the major way to prevent HIV infections. The whole point of both the AIDS transition approach and the cash-on delivery approach is that we leave the solution to that problem up to the local individuals and let them solve it. I was interested by the comment from the fellow who's from Oxford at the back, who says that these kinds of hands-off approaches might take us backwards. And I guess that's one reason why we're going to continue to fund inputs. But the other thing is that we haven't really done very well on HIV prevention. There's been a substantial decline in treatment, as you can see from the graphs from UNAIDS. For the treatment, you can actually see since 2003 a deflection in the number of deaths, which must be due to PEPFAR mainly, but also to other donors. You don't see that deflection in the new infections numbers. Africa is right like that, all the way from 1997 with no downward inflection. So we haven't got the answer. And I really agree very much with Ken's remarks on this, obviously. This answer needs to be worked out locally. If we have clarity in measurement, then those mistakes will get corrected.
So thank you to all of you, and could we give a hand to Mead and the panelists?